Hello, everyone. Our topic today is breathlessness, or scientifically speaking, it is called dyspnea. Objectives of our presentation. First, I would like to start with types of lung disease: airway disease, lung tissue disease, and lung circulation disease. This is a very important picture to kind of visualize the kind of problems that you will encounter when you deal with breathlessness. Also, we have cardiac causes of breathlessness. So, cardiac and lung are the most of the, the most important causes of dyspnea or breathlessness. Breathlessness is kind of more or less a layman language, sort of speak, than dyspnea. Dyspnea is more scientific. So, if you're just talking to a regular patient with no medical background, it's better to tell him this is breathlessness or shortness of breath, right? Instead of saying you have dyspnea, for example, right? Definition of breathlessness. Breathlessness or dyspnea is a common and burdensome symptom for patients with advanced disease. The American Thoracic Society describes dyspnea as subjective experience of breathing discomfort that consists of qualitatively distinct sensations that vary in intensity. The experience derives from interactions among multiple physiological, psychological, social, and environmental factors, and may induce secondary physiological and behavioral responses. So, as you see, this is a rather complicated and sophisticated definition. But, to summarize it in two words, dyspnea or breathlessness is a subjective experience of breathing discomfort. It is important to note that the subjective nature of the symptom is stressed along the multidimensional components, something very similar to pain, symptoms here, which go beyond solely physical condition and support the importance of psychological, social, and spiritual existential component. This is basically similar to the concept of total pain that's described by Cicely Saunders. We have what we call total dyspnea or total breathlessness. This term has been also suggested. Various terms are used in the context of dyspnea: difficult breathing, shortness of breath, breathing discomfort, or simply breathlessness. The term breathlessness is now widely used in palliative setting and breathlessness literature in preference to the biomedical dyspnea to emphasize the focus on the daily experience of breathlessness from the patient's perspective. So, in general, it's better to use the terminology breathlessness. Okay, this will help with patient communication better than using a scientific name like dyspnea. Again, we have total breathlessness, similar to total pain. We have physical components and we have non-physical components such as emotional, social, and spiritual components. Classification of breathlessness. The definition of dyspnea or breathlessness has recently been divided into breakthrough and episodic and continuous dyspnea. Time-limited episodic breathlessness, seconds to hours, is characterized by a severe worsening of breathlessness, intensity, or unpleasantness beyond usual fluctuation in the patient's perspective. The chronic breathlessness syndrome is described as experience of breathlessness that persists despite optimal treatment of the underlying pathophysiology and results in the disability for the patients. Again, we have persistent or continuous dyspnea or chronic dyspnea, and this represents 20% of the cases. And we have persistent plus breakthrough dyspnea, 20%. And we have also breakthrough alone, and this represents 60% of dyspnea. Episodes of, so I mean, to make it easy, just use the terminology persistent and episodic. I think this will be the easiest way, okay? Persistent is the continuous or the chronic, and then episodic is the breakthrough. Episodes of breathlessness can be predictable with known triggers, such as exertion, emotions, comorbidities, or external environment, or may apparently be unpredictable. Lynn Detail stated that many inexplicable episodes are driven by fear or panic when investigated. Dyspnea crisis is defined as sustained and severe resting breathing discomfort that occurs in patients with advanced, often life-limiting illnesses, and overwhelms the patient and caregiver's ability to achieve the symptom relief. So I'm throwing now some terminologies that we're going to use later on in the presentation. So we talked about persistent dyspnea, we talked about episodic dyspnea, we talked about dyspnea crisis, and again, we talked about breathlessness versus dyspnea, and as I said, we prefer to use the word breathlessness over dyspnea for obvious reasons. Okay, another terminology that I'm throwing here, refractory dyspnea. Refractory dyspnea is a debilitating symptom of an advanced pulmonary and cardiovascular disease. Remember, you know, the two common causes of dyspnea or breathlessness is either cardiac or lung, okay, or pulmonary. And there are other causes, of course, but I mean, these are the main ones, okay? Refractory dyspnea is characterized by difficulty breathing, persisting at rest, or with minimal exertion, despite optimal therapy of the underlying condition. The incidence of dyspnea increases in the last 3 months before death. Dyspnea is often poorly controlled despite numerous potential interventions. One systemic review evidenced breathlessness was experienced by more than 90% of patients with advanced COPD and more than 60% in patients from advanced heart disease, again, cardiac and pulmonary. Okay, this is an important model here that I want to just give some time to explain it. The breathing slash thinking slash functioning, BTF model. Breathlessness, so this model, I'm going to explain it in the next few slides here. Breathlessness does not only impact patient physical condition, but it imposes psychological distress, changes in social relationships, and often provokes spiritual existential concerns for patients and careers and carers. So I want to just put this into perspective here. I mean, when you get dyspnea or you develop, you know, episodic dyspnea or breathlessness, it's not about just being short of breath. I mean, it does affect you as a whole. Affects your mind. It affects your body, and affects your, spiritual, and emotional, composure, sort of. In early stages, patients suffer from the invisibility of breathlessness. Later on, living with breathlessness is often seen as an ongoing struggle with unexpected transitions into acute illness in form of acute exacerbations. Breathlessness is frightening and distressing, and many patients suffer from anxiety and panic, leaving them feeling vulnerable and open to attack by their breathlessness. I've seen this, guys, very common. Okay, patients that have dyspnea really, it's really a serious issue, and you have to tackle it in such a way because it triggers these, as I said, psychological, emotional, uh, you know, feelings when you get the dyspnea or the breathlessness attack you. Breathlessness affects individuals in different ways and different dimensions, which will be demonstrated by the breathing, thinking, functioning model, BTF model. This clinical model conceptualizes the three prominent cognitive behavioral reactions to breathlessness that, by causing vicious cycles, worsen and maintain the symptom. So BTF model, we have three domains: breathing domain, thinking domain, and functioning domain. Breathing domain, breathlessness is associated with dysfunctional breathing patterns with an increased respiratory rate, the need for use of accessory muscles, and dynamic hyperinflation, leading to insufficient breathing and increased work of breathing. The breathing domain is the physical domain. Okay, second domain is the thinking domain. Misconceptions about the nature of breathlessness, example, its causation, and previous experiences and memories of breathlessness having a profound impact on the present experience. These negative cognitions and memories can lead to anxiety, distress, feelings of panic, and thoughts about dying. So this is the emotional aspect. And then you have the functioning domain. People suffer from breathlessness frequently reduce their physical activity to avoid the sensation which leads to social isolation. The need for more help from others and deconditioning of limb, chest wall, and accessory muscles. So you have a breathing domain, you have a thinking domain, which will lead to a functioning domain, okay, by isolation. Patients will isolate, so they actually avoid the sensation, and this will lead to serious problems such as deconditioning of limbs, chest wall, and accessory muscles. Breathing, thinking, and function. So breathlessness will affect breathing, will affect thinking, and this will affect the function. Okay, caregiver burden. One of the most important complications from breathlessness is this caregiver burden, guys. Okay, when patients are suffering from breathlessness, this affects informal carers, families, and friends supporting the patients as well. However, their burden and anxieties are often overlooked, and their presence is taken for granted. Carers for breathless patients carry out many roles and tasks of caring, such as washing, dressing, managing symptoms, administering medications, or managing home oxygen. as long as doing all the everyday household work. Besides this practical help, they might also provide emotional support. Epidemiology. Breathlessness is a common symptom in general population, with higher prevalence in older age, female sex, and chronic malignant and non-malignant conditions. The prevalence varies across conditions, from 16 to 77% in cancer, 56 to 98% in chronic obstructive pulmonary disease, 18 to 88% in chronic heart failure, 11 to 82% in end-stage renal disease, 12 to 52 in dementia, and 81 to 88% in motor neuron disease. Large variations are due to different ways of measurement and different disease stages. In the last months of life, breathlessness intensity increases as death approaches, especially in patients with primary lung cancer. Pathophysiology. Breathlessness, or the uncomfortable awareness of the need to breathe, is a complex individual experience of the mind and the body. It's basically, guys, same like pain. I mean, when we talk about breathlessness, try to compare it to pain. Okay, it's a complex subjective feeling. This helps to explain the clear evidence that breathless severity is a better predictor of prognosis than the disease severity measured by quantitative assessments such as pulmonary function tests. So this will lead us to an important concept here. Assessing, breathlessness is a better predictor than measuring it by quantitative assessments. So again, this gets us to the same concept that breathlessness is a subjective phenomenon, guys. Respiration is the only vital function that's both unconscious and under voluntary control, enabling the individual to talk, sing, eat, or breathe, breath hold, to swim underwater, for example. The respiratory breathing center in the medulla and pons generates respiratory rhythm, which is then modified by connection through the brainstem and upper spinal cord. It coordinates the activity of the diaphragm, the intercostal muscles, and the accessory muscles of respiration. The links between different parts of the brain and brainstem and respiratory muscles continue to be very controversial. It is clear that the sensation of breathlessness originates from the complex neurophysiological interplays between the automaticity of the breathing center and the brainstem and the generation of the fear and anxiety in the amygdala and limbic system, and the influence of higher cortical thinking and feeling areas. To wrap this up, basically, again, breathlessness is both physical and non-physical, right? And the non-physical is basically sensed at the limbic system, exactly like pain. Okay, this is the area where your emotional experiences kind of develop, and it does affect your psychological, makeup as a whole. So this nice picture shows you, the physical components here that's affecting breathing, including, the respiratory center, which is located basically in the medulla and the pons. This is the one that's responsible for, the breathing process itself. It's affected by so many factors like stretch receptors in your lungs, irritant receptors, peripheral chemoreceptors, central chemoreceptors, and then other chemoreceptors. But again, we have an emotional component here that's sensed by the limbic system in your brain. The sensation of breathlessness is integrated throughout the central nervous system, influenced by peripheral generators, like we mentioned in the previous picture. Again, another nice picture for the pathophysiology of breathlessness here. The presence of physical consequences of the disease, such as distortion, stretching, or stiffening of the lung tissue by fluid, inflammation, or tumor, or hypoxemia, are transmitted to the breathing center by, for example, pulmonary stretch receptors and large vessel chemoreceptors. All of these can lead to dyspnea, hypoxemia, acidosis, decreased lung compliance, airway resistance. All of these will lead to, triggering of the breathing center or the respiratory center that's located in the medulla and the pons, leading to dyspnea. Causes of breathlessness: infection, anemia, deconditioning, hypoxemia, hypercapnia, metabolic acidosis, bronchospasm, pulmonary edema, pleural effusion, restrictive process such as trust, wall restriction, decreased lung compliance, pneumothorax, pulmonary embolism, muscle weakness, airway, mechanical obstruction, lymphangitic carcinomatosis, pulmonary hypertension, pericardial effusion, and ascites. I have also a very nice picture here that shows you, the main two causes of dyspnea are pulmonary and cardiovascular. I like this picture because it really wraps the whole, or this diagram, the whole, important causes of dyspnea. And then here in the bottom, it tells you there are other, causes like acidosis, for example, or anxiety, deconditioning, pain. All of these can lead also to dyspnea. But the main two sources are pulmonary and cardiovascular. Assessment of breathlessness is through a comprehensive clinical history of a patient, and basically this should include the pattern of breathlessness, presence of other symptoms, impact on a person's quality of life, current symptomatic treatment, adverse effects of any treatments used currently or in the past, all comorbidities, the person understanding and interpretation of the symptom. And don't forget at the bottom here, but it's, this is super important, is the carer burden. Validated measures. So, as you know, we have the breathlessness is included inside the ESAS, okay? But for research purposes, we have two validated measures, the Dyspnea 12 and multidimensional dyspnea profile. I'm not going to go in detail about these two validated measures, but just have this in mind in case if you're planning to do research on breathlessness. These are the, things that you need, in your to use in your research. The Dyspnea 12 or MDP, both of them are 12-item scales, okay? So this is basically, what we call the Dyspnea 12 and multidimensional dyspnea profile, MDP. Diagnostic testing. Although additional diagnostic testing may be important to identify any treatable causes of breathlessness, one could be aware that more objective assessments such as respiratory rate, blood gas analysis, lung function tests do not measure breathlessness and only correlate moderately with the patient's subjective experience of breathlessness. Guys, this is exactly like, pain. I mean, patients could come to you with severe pain, and when you look at their pathology, it's not that bad. Okay, this is very common because it's not just physical type of pain. It's physical and non-physical. Everybody's response is different. So be careful about evaluating the breathlessness. Patient might be really suffering. And when you look at his X-rays, for example, there's that blood gases, pulmonary, it's not that terrible. Okay, so you have to put this in mind. You're treating the patient. You're not treating the X-rays. Okay, be careful about this. Generally speaking, when we manage the dyspnea, we have to start with a root cause. So if I have something that I can fix, for example, bronchospasm, then you need to give bronchodilators. A patient has RALS, his lung is wet, you might need to add some diuretics. If he has an effusion, either pericardial or pleural effusion, you need to do thoracocentesis or pericardiocentesis, for example. Airway obstruction, well, this will cause dyspnea. Then you need to do what is necessary to be done, either a tracheostomy, stenting, or doing a bronchoscopy, having thick secretions, anticholinergic agents can help with that, for example. Low hemoglobin, and this is important, guys, okay? Anemia. Okay, we said the two main causes of dyspnea are both cardiac and pulmonary, right? But there are other causes. One of them is anemia. This is systemic cause, and we see it a lot. And I want to say that as a palliative care physician, I do give patients at end of life, sometimes I give them a blood for the purpose of the fatigue and the dyspnea. I mean, because the patients feel, functionless. He cannot go anywhere. He cannot do anything. So sometimes I just bring the patient and give him blood. This is okay. This is a palliative measure. This is not, a curative measure. I'm not trying to treat the anemia to bring him back to life, sort of. I mean, we're just treating the anemia to help with his symptoms. I like this pyramid. I mean, it reminds me also with the WHO analgesic ladder, okay? Starting with treating the underlying disease, psychosocial support, step 2, pulmonary rehab, multidisciplinary breathlessness, trial of a fan, and then, systematic low-dose opioid. We're going to talk about it, and trial of oxygen if patient is hypoxemic. I'm just saying, this pyramid really helps you out to sort out your priorities, okay? So, I mean, don't jump on the opioids, right? I mean, before you try to treat the underlying disease, right? Or give oxygen and the patient is not hypoxemic. It's just waste of time, right? Non-pharmacological therapies. When breathlessness persists despite optimal management of underlying condition, symptomatic treatment is mandatory. This comprises both non-pharmacological and pharmacological measures. Earlier in the disease trajectory, non-pharmacological treatments are the first choice, with the aim to improve patient self-management and increase physical activity. The BTF model is helpful to classify available non-pharmacological interventions for breathlessness. These should be proactively introduced to the patients, as they are the cornerstone for the breathlessness management. This is a very common question in the board exam. Guys, you have to always think about non-pharmacological before you get into pharmacological. All right, this is the bottom line of this whole slide here. So we're using this model, okay? So this gets us to this BTF model again. All right. Now we found an application for the BTF model. It's not just something theoretical or academic. We're using this BTF model for treatment, for using non-functional, for using non-pharmacologic techniques for breathlessness. So, for example, breathing. You can use breathing techniques. You can use handheld fan. You can use airway clearance techniques, inspiratory muscle training, chest wall vibration. All of these are non-pharmacologic techniques. Non-invasive ventilation, as far as the thinking, the T component of the BTF, cognitive behavioral therapy, relaxation techniques, mindfulness, acupuncture, and the F in the BTF model of functioning, pulmonary rehabilitation, activity promotion, walking aids, pacing, and neuromuscular electrical stimulation. Breathing techniques. As breathlessness is causing dysfunctional breathing with excessive accessory muscle use on upper chest dominance, readaptation of breathing patterns is essential in breathlessness management. Breathing control and diaphragmatic breathing are the two commonly used techniques. So remember these two techniques. These are things that you need to teach to your patient. Okay? So use either the breathing control or the diaphragmatic breathing. Diaphragmatic breathing prolongs and slows inspiration and deliberately increases the tidal volume, but should not be advocated in patients with severe COPD. While breathing control techniques maintain normal tidal breathing with relaxed upper chest and shoulders. So and then we have another third technique is the pursed lip breathing. It's further frequently used breathing technique and is frequently and often instinctively used by patients as a potential strategy to reduce respiratory rate and aid in recovery, especially in COPD patients. So we added another one, which is the pursed lip breathing. So we have three techniques: diaphragmatic breathing, and you can use it in most of the patients except advanced COPD. Then you have the breathing control, and then and this one can help in most of the patients as well, including patients with severe COPD, because it's using or maintaining a normal tidal breathing. And then pursed lip breathing is something patients, they do it, instinctively. Okay, because they produce like a CPAP-like effect, and this helps with the breathing. So that you will see them doing this even if you don't teach them how to do it. This is a diaphragmatic breathing. As you can see, you have to put your hands on your belly while you're taking a deep breath, and you have to feel your belly is moving, expanding, okay? When you do inhalation and then doing exhalation. Okay, breathing control. We call it the 3-2-4. Breathe in through your nose, breathe out through your mouth. So count to 3, breathe in your nose, and then 2 for the pause in between the inspiration and expiration, and then breathe, count to 4. 3-2-4. 3-2-4. Pursed lip breathing. Breathe in, breathe out. Look at the lips, how they are basically, uh, they just, you know, they do like a pursing of their lips while you're breathing to create this positive pressure. As I said, something similar to CPAP, natural CPAP. And this allows the alveoli to expand. Okay, another important, way to non-physical, non-pharmacologic technique is the hand-held fan. Guys, this is, couldn't be more simple than this. All right. The airflow on the face reduces breathlessness by altering ventilation. And basically, they do believe that this is really related to stimulation of the trigeminal nerve, which gives the sensory input to affect the respiration and decrease breathlessness. And we have a lot of evidence behind this handheld fan. Okay, like for example, we have a recent study that showed chronic breathlessness reported that a handheld fan was experienced as a helpful for breathing by 85% of the patients. Moreover, 54% reported that a handheld fan increased physical activity. It couldn't be simpler than this. Acupuncture. Acupuncture is widely used in traditional Chinese medicine, and its efficacy and practice has been demonstrated. A systematic review examining the effects of acupuncture in breathlessness patients suffering from advanced disease included 12 studies with 597 patients with COPD or advanced cancer, and demonstrated that breathlessness severity decreased significantly. One of the points that I love to teach my patients are called the ASAD points, or ASAD points, anxiety, stress, and dyspnea points. And these are located mainly on the front of the manubrium. Okay, and I encourage the patient to rub this area with their hands when they feel dyspneic. It's very simple maneuver. This area is pretty sensitive, by the way. Okay, and just a nice pressure over the manubrium, in a circular motion here, can help quite a bit with dyspnea, and sometimes with stress. I use it myself for stress. Okay, and sometimes I use it for anxiety as well. I rub this area with my hand. Very nice. By the way, if you think about it, patients with having a heart attack, you'll find them rubbing this area instinctively, okay, without even training or anything. It's like, their body just tell them to use this area to help with their, the stress, sort of. I found this point here. It's called the infraspinatus trigger point. Because I'm a pain doctor, so my background kind of, also sometimes I like to intervene, do some trigger points. Guys, these patients with breathlessness, they have myofascial trigger points all over the body. But seemingly this one is very specific. It's in the middle of the infraspinatus muscle belly. And I usually just put a little bit of local there, and it's pretty safe because you have the scapula in front of you. You're not going to get pneumothorax or anything. You will hit the bone, if you go too deep. So I like to do this injection in my office, and let me tell you, immediate relief, immediate. Unfortunately, it's for short term. But the patient gets out of your a clinic very satisfied. Psychotherapy, okay? So cognitive behavior therapy plays an important role, in breathlessness here. And we have evidence in the literature, like this study by Bob, they favor CBT. A trend of favor CBT was shown, but the results are not significant after 12 weeks of follow-up. Okay? In the studies testing personalized psychoeducation interventions, self-reported breathlessness was unchanged. So it does help, but it's not significant on the long term. Mind-body interventions. Norwig et al. Reported the systematic review small large dyspnea improvements resulting from yoga. Okay, so it's not very significant, but something to put in mind. In a study evaluating 8-week mindful-based breathing therapy program, the intervention group did not show any significant reduction of breathlessness. You know, I don't. I mean, I want you to take this, studies with a grain of salt. I myself, like to teach something. I'm not a yoga master. I don't know about yoga. I mean, just very superficial. However, um, I use something called chair yoga. Okay, you don't want to use the word yoga. I don't care. Don't use the word yoga. Use, I mean, yoga is a stretching exercise. I tell the patients we're gonna have a very simple stretching exercise while you are sitting on the chair. I mean, how easy is that? Okay, and if you look at the NHS website, they show you like these exercises, how you do them. I mean, it's super simple. Okay, please look at the NHS website for chair yoga. You will find a picture in the net that you can, basically make, some copies and give it to the patient and ask him to do this, stretching while he's sitting on the chair. Because, I mean, let's be realistic. These patients are pretty sick. I mean, you're not going to ask them to do a very sophisticated, yoga actions, like, I mean, they have all kinds of stretching over there. But this one is pretty straightforward. Okay. Music therapy. Studies testing music are referred to as distractive auditory stimuli, DAS. Okay, so we like to use new terminologies here. So DAS is basically distractive auditory stimuli, and there are two small studies, in COPD patients. In the study testing the DAS during walking, a non-significant decrease was observed in the intervention group and a non-significant increase in the control group. In the second study, no significant differences between or within groups were shown. Singh et al. Compared the effects of music with progressive muscle relaxation and demonstrated that both groups were clinically effective in immediately reducing breathlessness. The improvements in breathlessness and anxiety were higher in the music group than patients with progressive muscle relaxation group. I mean, in other words, it's another gadget that you can try. This DAS, distractive auditory stimuli. Also, progressive muscle relaxation, which can be effective somewhat as well. Anything that will reduce the anxiety, same like with pain, it can help. Okay, as you see in this picture, this is in Turkey. They doing Sufi music in the ICU. Okay, and this can help with reducing the stress. Physical exercise. As many patients experience unpleasant breathlessness, especially with exertion, they reduce physical activity, which in consequence leads to muscle deconditioning, which drives further breathlessness at lower levels of activity. Therefore, physical exercise should be encouraged in patients with breathlessness. Exercise leads to improvement of fitness and muscular performance among people living with and cured of cancer. So physical exercise is important. Of course, you have to do them according to their level of tolerance. And I mean, physical exercise is a key component in the pulmonary rehabilitation programs. Mobility aids, such as rollators or walking sticks, offer breathless patients additional support and not only allow for walking longer distances, but also improving breathlessness. So I would use something like this, to help the patient walk around. There's nothing wrong with that because this will allow them to improve their mobility. Neuromuscular electrical stimulation, or NMES, is also another way to help with breathlessness because deconditioning is a common symptom in these patients. Deconditioning due to physical activity or lack of physical activity also leads to breathlessness and peripheral muscle weakness. Therefore, exercise training is a key component of pulmonary rehabilitation programs, but not all participants with severe COPD are capable of exercise and exercise training. So this is a technique that we use in those patients that are not able to participate in exercise training. The neuromuscular electrical stimulation provides an interesting and alternative technique to improve lower limb muscle performance. Low current is applied to leg muscles, mainly the quadriceps, by a device causing the muscle to contract. NMES doesn't have the same effect as aerobic or weight training, but the aim is to prevent or slow the downward spiral that can affect the breathless patient, not to reduce breathlessness directly. So it's clear we're trying to improve the muscle function so the patient is able to ambulate. And this will indirectly affect your breathlessness. And we have a study by Jones et al. Demonstrating, 933 patients with chronic respiratory disease, chronic heart failure, thoracic cancer that received the NMES led to statistically significant improvement in the quadriceps muscle strength as compared to the control group. And this led to improvement in exercise performance with mixed results in breathlessness. So this is kind of the one on the left is NMES. Okay, this is not a TENS unit, guys. Okay, don't confuse them together. TENS unit is for pain, for the sensory part of the pain. But NMES is, in fact, for the muscle. It's stimulating the muscles, particularly the quadriceps muscle. Pulmonary rehab, there's a strong evidence pulmonary rehab has significant effect on breathlessness, increases functional exercise, and improve the quality of life in COPD patients, as demonstrated in a Cochrane review, including 65 randomized controlled trials in more than 3,000 participants. So this is part of the, and we said also incentive spirometry, of course, and also the exercise program. Support services. For optimal management, for breathlessness, several management strategies are used, and especially in patients that are not fit enough to participate in longer pulmonary rehabilitation program. Therefore, the breathlessness services have been developed and evaluated over the last 20 years for patients with advanced disease following the Medical Research Council framework for complex interventions. Opioids. So opioids are the preferred treatment of breathlessness with good evidence. Endogenous opioids have a mandatory effect on breathlessness, which appears to be mediated by binding to the central rather than peripheral opioid receptor in the respiratory tract. So these opioids work on a center in your medulla called the Pribot-Zinger complex, which is part of your inspiratory center. And it basically dampens this center and helps reducing the anxiety associated with breathlessness. Pribot-Zinger complex. With opioids, it's not like pain. We use much lower doses than pain management. Okay, so be careful about this. Okay, this is just a small dose to help with the inspiratory center. So, for example, using, for example, 10 milligram morphine per 24 hours or up to 20 milligram. Now, basically, do not exceed 20 milligram morphine or its equivalent per day. Okay? And you can use any opioid. Morphine, hydromorphone, fentanyl, doesn't matter. All of them work. Side effects of opioids, of course, the most important and feared side effect is respiratory depression. And the rest of the side effects are well expected, like any type of opioid therapy. Nausea, vomiting, constipation, and others. Benzodiazepine is considered a second choice after opioid, especially in patients with a large component of anxiety. Okay, but Cochrane review failed to show any benefit of benzos in breathlessness. I try to avoid them because combining benzos with opioids can be hazardous and can cause respiratory depression, as you know. But sometimes, the opioids are not sufficient and patients pretty anxious, uh, you know, and if the patient is a responsible patient, you can add a very small dose of benzos. Antidepressants, one of the nice drugs that I like is mirtazapine. We call them the NSSA, antidepressants. This is our preferred choice of antidepressants in palliative care because it plays multiple roles. It helps with sleep, helps with appetite, helps with nausea, helps with breathlessness, helps with mood, helps with different, uh, you know, symptoms at end of life and palliative care setting. Oxygen therapy is also commonly administered to patients suffering from breathlessness due to advanced disease, often in the belief that it's beneficial to patients. However, evidence is very mixed. I mean, definitely oxygen therapy helps in patient that has hypoxemia, you know, um, chronic hypoxemia. Then you can, and COPD. In these situations, you can give the LTOT or the long-term oxygen therapy. This has been established, measured, and recommended in numerous guidelines for prolongation of survival. But in breathless patients, mild or no hypoxemia, evidence is very limited. Okay. However, and I put this in blue here in the slide. Oxygen can relieve breathlessness when given during exercise, and this is the advantage, in these patients. But if the patient is resting, there's no point to give oxygen, especially if he's not hypoxemic. Uh, also, they've shown that actually the airflow to the patient through the nasal cannula helps the more than the oxygen itself, because again, it's the same concept like the air fan, the handheld air fan, right? It stimulates the trigeminal nerve, okay, and this has an effect on your breathing center. So you don't need really oxygen to do that. You can use just a handheld air fan. And this is just some examples of oxygen tanks and concentrators and all that. Non-invasive positive pressure ventilation is also important. Okay, and I mean the CPAP and the BiPAP. The CPAP is more helpful in especially in respiratory failure type 1, that's accompanied with hypoxemia, while the BiPAP is for patients that retain CO2. And these are considered palliative measures, guys, okay? So we use them in our unit all the time and help those that needs, a little bit of support, while breathing, especially patients with respiratory failure here. Dyspnea crisis. I like this mnemonic, comfort for patients with dyspnea crisis. Remember, we have dyspnea crisis, and we talked about it early on in the presentation. Call for help, observe the degree of respiratory difficulty, medications, fan, oxygen, reassure, treat the cause if possible. Comfort. Key learning points. Breathlessness is a subjective experience that derives from interactions among multiple physiological, psychological, social, and environmental factors. Informal caregivers are severely burned and need attention of professionals. The BTF model conceptualizes the three prominent cognitive and behavioral reactions to breathlessness that, by causing vicious cycles, worsen and maintain the symptom. Breathlessness is a complex interaction of mind and body, influences both by peripheral changes in the lungs as well as cognition and memories. Assessment of a patient with breathlessness should include pattern of breathlessness, impacts on patients' quality of life, including physical activities and the person, understanding and interpretation of the symptom, treatment of underlying disease, and the reversible causes are the first step in breathlessness management. A variety of non-pharmacological therapies are available with good evidence that can be individually tailored to the patients. They should be employed before starting with pharmacological treatment. For pharmacological therapies, opioids are the drugs of choice with good evidence. Benzodiazepines should only be used in combination with opioids as their evidence is limited. Oxygen should only be prescribed to hypoxic patients. Otherwise, a draught of cool air generated by a handheld fan should be introduced to the patients as there is a good evidence for relief of breathlessness. Thank you.